holistic view session tonight or this afternoon. Am presenting Shang Li Yang, who holds a MSW, LCSW, and PMH-C, which I don't even know what that stands for. So Shang could explain all the amazing after her name. So Shang is first generation Hmong immigrant who arrived in the US as a refugee at an early age and has remained in Wisconsin since. Today, she is a practicing licensed clinical social worker, president and executive director for IBHiAP Healthcare. Additionally, she teaches graduate level courses in clinical mental health and diversity and inclusion, and more importantly, is a proud mother of 2 young girls. Her professional experiences include direct care in leadership positions in public, private, government, and nonprofit institutions. Her personal and professions experiences help cultivate a vision to integrate social justice and cultural humility into mental health. On September 3rd, 2019, Shang led the opening of IBHiAP Healthcare to increase access to healthcare in the community. It is my pleasure to present you, Shang.
Can you guys hear me okay over there? Live stream can hear. Okay, so I typically like to use my stage, but I will be locked up right here. So if I look like I'm frozen and still, because I am. Thank you, Chair, for that very kind introduction. Again, my name is Shang. I'm a licensed clinical social worker by trade. I identify as Hmong, and the PMHC stands for Perinatal Mental Health Certified Therapist. So nothing special. Where's my clicker? All right, so today we're talking about maternal health and safety in Wisconsin. And many of you probably looked at the agenda and said, well, what in the world is this? I'm either not going to go to it or maybe I'll go learn something about it. A little bit about us too and myself is that about a year and a half ago, we partnered with DHS, so Department of Health Services, to really bring awareness to the Brown County and Fox Cities area around the space of perinatal mental health. Our state currently earned a D for perinatal mental health, but particularly our area of the Brown County and Fox Cities area, we really didn't have any mental health trained providers in the space of perinatal mental health. And so with this partnership with DHS, we were able to, or the goal is really to increase awareness and capacity for providers and therefore support on maternal mental health or what I call perinatal mental health populations. On the screen here is just a little bit about who us two is. So like I said, since we partnered with DHS about a year and a half ago, we have been doing a lot of trainings around the space of maternal mental health, really understanding what that looks like. How does intimate partner violence, right, and white supremacy really contribute to this issue? But then also, what can we do about it for ourselves? Or, what can we learn about it and then bring it back to our own organizations? All right, so our course objectives today, we're going to really learn about the prevalence of domestic violence and sexual assault and how implicit biases really is integrated or can impact, right, maternal mental health or maternal and infant death, particularly here in Wisconsin. I sit on the maternal mortality death review team for the state of Wisconsin. And unfortunately, right now, the statistics are overwhelming and alarming in the terms of the number of women or people who identify as women or birthing people who are dying either by mental health or substance abuse. And so I'll talk a little bit about those statistics. And again, how does domestic violence or sexual assault really impact those numbers? And then what are some solutions, right? How do we respond to this crisis to a system that really has failed birthing people and families overall? Always feel free to ask questions. I know presenters are very different about Q&A. If I'm presenting on something and you want to ask a question, because if you're like me, you might lose that thought, feel free to ask right away. Just raise your hand. I don't mind at all. All right, so when I talk about, or when we talk about domestic violence and sexual assault, right? We talk about power and control, the most common thing that comes up to or comes to mind, right, is usually like physical abuse, sexual abuse, maybe emotional abuse. But how many of us have heard of reproductive coercion and abuse? So a couple of us, okay. So reproductive abuse is when someone tries, right, or when a person tries to control their partner or another person about reproductive choices for the purposes of power and control. So this could be through like sexually manipulated behaviors. We often see that or hear about that maybe in sexual abuse, right? But sabotaging birth control and then pressuring somebody to get pregnant or have more children. So reproductive abuse is a little bit different than sexual abuse, but it essentially is an arm of sexual abuse. Since the overturn of Roe versus Wade, the numbers of reported cases of reproductive abuse has gone up dramatically. Because not only did we overturn Roe versus Wade, many states implemented laws and policies that would really make it difficult for a person who identifies as a woman to obtain birth control. So our really, like I said, our focus today is really going to be a reproductive coercion or abuse here. What does that typically look like? Well, in reproductive coercion and abuse, people who experience intimate partner violence, right, often receive really minimal prenatal care, if they receive any at all. And we know how critical prenatal care, right, is to infants, to babies, but also the mother themselves. Does this mother or does the birthing person have a history of medical complications that we need to be aware of? Are they at high risk for certain diseases and complications that we need to be aware of? And again, is the infant or the unborn child at risk? As a result, individuals who are facing or are being challenged with reproductive abuse are at a much higher rate or risk for adverse pregnancies, outcomes, and low birth or preterm birth, and also stillborn. That's why it is so critical for us to screen for intimate partner violence during the perinatal period or during perinatal exams. I know there was a huge push for, right, any provider, emergency room doctors, PCPs, nurses to be screening for intimate partner violence. I highly doubt that this is being done in the OB office, and if it is being done, it's probably not being done consistently and or screened appropriately. Any questions with this slide? Screening? Yeah. So if I was either a nurse or an OB or somebody who worked in the OB unit, I think simply just asking on a one-to-one basis, right, when there's nobody else in the room, was this a planned pregnancy, right? We never want to say unwanted pregnancy because it has a very negative connotation with it. So was this a planned pregnancy? How do you feel about, the other partner that's involved with, the baby? Are you afraid for yourself or the baby? So essentially, really the same way that we would screen in an emergency room, right? But really ensuring that we are asking those questions, maybe even at the first appointment. And if you're in the space of prenatal care and a birthing person is presenting to you maybe really late into the pregnancy already, those are probably some high risk, like high red flags, right? If somebody is in their second or third trimester, and they haven't received any form of prenatal care, that may be really a red flag to say, okay, why hasn't this person come in for services? Is it a cultural thing? Maybe it's a lack of access, or was it because they weren't allowed to because of the power and control piece? Mm-hmm. Mm-hmm. The other piece in understanding reproductive abuse is that many birthing people or women, right? Because most of the time it's women who are birthing. they don't realize that this is actually a form of abuse and it is a form of power and control. Because society still has this stigma that it is a woman's role, right? We live in a very patriarchal system, that it is a woman's job and a woman's role to give birth and have children, right? To reproduce. And so the victim themselves or the survivors themselves might not even be aware that this is happening to them because of the external stressors and because of the external stigma that comes with it. So what happens when somebody may be experiencing reproductive coercion or abuse? So these are just some statistics on perinatal mental health, right? And so this is just mental health themselves now, not maternal health overall. Perinatal depression is the #1 complication of childbearing. Keep that in mind. 10% experience depression, right, during the pregnancy time. So when we talk about perinatal period, I should just, clarify. Perinatal period is from conception all the way up to about 18 months to 2 years postpartum. And so oftentimes when we talk about maternal mental health or maternal health, folks will refer it to just 6 weeks postpartum, maybe 3 months postpartum, whereas perinatal really looks at up to 2 years postpartum. And during the pregnancy as well. So childbearing or perinatal depression is the #1 complication in childbearing, and it is the it's common in 10% of individuals who are pregnant. About 8.2% of postpartum depression or 16%, I'm sorry, of pregnant women develop anxiety. I'm supposed to see that screen and it's about this big to me, so I apologize. But the other piece that I want us to pay attention to is that 1 in 10 men also experience postpartum depression. So there's a lot of research and there's a lot of literature being done right now around postpartum depression on men or fathers or people who identify, right, as male, and how does the birth of a child maybe contribute or trigger, right, postpartum depression as well. And those ratings and scales are all of the same tools that we would use for women population. And then about 18% of men develop postpartum anxiety. So as I mentioned earlier, at us too, we do a lot of work around perinatal populations, and we have an inclusive parenthood program. And so we really make sure that we're also screening fathers or the other partner when we get a referral, so we can really understand if the father or the other partner is also experiencing mental health symptoms, or are they either a risk factor or a protective factor, and how do we work together as a family, right? But we're also screening for those signs of domestic violence and intimate partner violence as well, because we know that even if there was no reproductive abuse prior to the birth of the child, we know that domestic violence and divorce rates go up drastically during the first year that a child is born in the home. And then also 20% of people who give birth, right, in the first or in the perinatal period actually experience suicidal thoughts or take acts of self-harm. Now let's look at postpartum or perinatal abuse. 10% of pregnant women reported current alcohol use during pregnancy. 40% reported current use of one or more of other substances. It is very common for polysubstance abuse during the perinatal and maternal period time. And if, as providers, as individuals who work, with the domestic violence and understanding how does substance abuse then, right? How did we get here? As somebody from the earlier session talked about, one of our speakers, substance abuse and mental health are really just, right, the result of the consequences of something of a root cause. Mental health and substance abuse are oftentimes the root cause of domestic violence. 7% of pregnant persons reported using marijuana while they were pregnant. 1 in 10 pregnant women reported using alcohol while pregnant. And then 1 in 20 reported using other drugs. So again, we're really seeing here, right, that polysubstance abuse during the pregnancy period. And although 80% of people reported they were using alcohol to their OB, only 16% were advised or given support on how to reduce or stop drinking. 80% reported. 80% of the people that were screened, right, reported that they were using alcohol or consuming alcohol while pregnant, and only 16% were actually, advised to stop or reduce or encouraged to reduce the drinking. That's a 60% difference. I think a lot of the literature out there is mixed, and because there's not clear literature about how much alcohol is, I guess, safe to consume during pregnancy, the recommendation now is no alcohol. Because what we have to, it's not just about like, did you consume alcohol or not, right? We have to consider, does the fetus or the baby have maybe any pre-exposed, right, or genetic issues that may be impacting or would put them at higher risk if the mom is using alcohol. At what trimester, right, are we consuming alcohol? Because every trimester is different with the development of the fetus. And so right now, many providers and many literature and research is saying, because we can't consistently say when is it safe or how much, don't even do it. Now, of course, if we have a parent or a birthing person that has a history, right, of alcohol use disorder and is physically addicted, right, and has a physiological addiction to alcohol, then we need to work with an OB and a psychiatrist to really taper off the mom in a way that's going to be safe for mom and fetus then. That's a good question. I was like, how much is safe, right? Because I think for a while it was like one glass of wine a day equivalent or something. Go ahead. Yes. Yep. So 80% of the people, so of all of the people that were screened, right, 80% of the pregnant people were asked about alcohol consumption at OB visit, right? And only 16% was advised to either stop drinking or reduce their drinking. Yep. Yep. Another hand back there. 40% of other substances. So that could be, methamphetamines. It could be any illicit drugs. So 40% reported current use of one or more other substances. So that's the polysubstance abuse. So somebody could be using both alcohol, cigarettes, and marijuana, or taking prescription pills and using methamphetamines. Yes. 40%. Nope. So these are all different groups of people and statistics. Yeah, they're not the same study. Yep. And these are statistics from the CDC, and so they're readily available to anybody who's interested in looking at it more. Any other questions about this slide? What year was this done? Yep, it's going to be the most recent. So within like the last 2 to 3 years, the CDC has different publications for like alcohol, marijuana, polysubstance use, prescription pills, opiates. And so you'll have to kind of click through depending on what you're looking for. And then there's different years of publication, but it's within the last 3 years. Why do we think that the statistics are so high? Yeah, COVID, isolation. I saw a hand over here. Yep. Absolutely. Yep. And we're assuming again that all of these people, right, or that every pregnant person wanted the pregnancy or wants to continue the pregnancy. Mhm. So let's talk a little bit about the maternal mortality. As I mentioned, I sit on the maternal mortality death review team here in the state of Wisconsin. It's never a fun meeting, right? It's you review files and pages of people who have died as a result of pregnancy and or pregnancy related issues. And um, so in the United States, which with the latest statistics, 1,205 women died of maternal causes in the United States in 21. In Wisconsin, right, 80% or 80 pregnant associated deaths in Wisconsin between the years of 2016 and 17. 33 of those deaths were pregnancy related, so about 41%. And I know many of us are thinking, well, that crap is from 2016 to 17. Like, why, it seems outdated, right? But it's actually not. And I was actually one of those people that was critical of it because I'm like 16 to 17 is a long time ago. It's not relevant. Well, the reason why it takes, go ahead. Yeah, so the pregnancy related and pregnancy associated is super complicated, I know. One means that the pregnancy associated means that you died because of something real like pregnancy related, right? And the other is like I was pregnant at the time of death, but it was like a homicide, right? So one has to do with more like medical versus internal versus external is probably the best way I could put it. Mhm. And so going back to the conversation about, why is this publication so late, right? 2016 to 2017 is the most recent publication. The reason why it takes so long for the state to release this data and do an actual publication is because it requires a whole set of, professionals and team members to review the death records and the history of everybody so what we do is we review the history and the death of everybody who died, that had a baby within the last year. And then you review and you do a full history on everybody. And then you take the folks that are either pregnancy related or pregnancy associated, and then you do your data and your research based on just that number, right? And so that's why these publications from the state of Wisconsin takes very long. 73% of pregnancy related deaths occur during the postpartum, right? So after up to 1 year postpartum of when the child was born. 52% of mental health and substance abuse contributed to the death of individuals who died during pregnancy and or postpartum. So 52% of people who experience maternal mortality died because of mental health or substance abuse related issues. 48% of all pregnancies related deaths in 2016 and 17 are due to an overdose. So those numbers are pretty significant. Of course, again, we know that with COVID, that really exacerbated mental health and substance abuse issues, but also it really exacerbated domestic violence, right? People really weren't able to seek help, especially with the emergency stay-at-home order for the first month or so, right, of 2020. That really caused a lot of problems for society as unfortunately a negative implication of domestic violence. Okay, so again, more stats and data here. So this is again from the 2016 to 17 Wisconsin maternal mortality report. It's on the Wisconsin DHS website. You're free to go and review the publication. But if you look on the top, so on the very top there, right? While Hispanic, non-Hispanic, Black, Asian, and pretty much minoritized communities and populations made up only 24% of Wisconsin births in the year of 2016 and 17. They represented nearly 1/2 or 42% of all pregnancy-related deaths. So you can definitely see there through the statistics that there is some systematic issues going on there. And we really have to understand how is it that minoritized communities or individuals women who identified as non-white made up a larger number of pregnancy-related deaths. And then on the further right there, we're looking at then, right, what are some of the contributing factors that may have some things that may have contributed to the death of the person. Discrimination was about 21%. This is something that we constantly are reviewing. How do you measure discrimination, right? When we're trying to backtrack someone's health records, when we're backtracking someone's death and trying to understand, did they have access to equitable care? Was there something very obvious, excuse me, in their health care or access to health care? But if it's not documented, how do you prove that? But in the cases that was really blatant and obvious, 21%. 21% of the deaths in 2016 to 17 was obvious discrimination related. Again, 42% was substance abuse related, 67% was mental health related, and then 15% was obesity. And these are measures that are so the factors that we are looking at, those are actually asked from us as a committee and as a team from the CDC. And so every state, except for 7 states, has their own maternal mortality review team. And though these different pieces that we are looking at are recommended by the CDC. So somebody over here, I think you asked me, person in the front here, what is the difference, right, between pregnancy related and pregnancy associated? So here's kind of the different breakdowns. So the pregnancy associated includes natural accident and homicide, but it's so hard to say what's truly an accident, right? Because we know that many people die by suicide in an accident. Right, car accidents, right? That is just on the death certificate says it's car accident. And we also know that a lot of people die by, die in domestic violence. That's really a homicide, but it's labeled as an accident or suicide. And so those numbers can really be skewed. More importantly, though, 97% of all deaths are preventable. Homicides are preventable, right? Accidents are preventable. If somebody was driving in the car and got into a car accident because they accidentally ran a red light, that's preventable. So if we look at this case, if we look at this chart, only 18%, right, of pregnancy-associated deaths are natural causes. 45% of pregnancy-related are natural. 97% of cases are preventable. These numbers are really alarming. Now we look at the flip side of what is the impact on domestic violence, reproductive rights, right, on infant mortality and low birth rate. These are this is pulled from Wisconsin DHS publications on birth outcomes in 2021. Again, anyone is free to review it. But in Wisconsin, the stillborn rate by birthing parents characteristics here. So we see all of the minoritized populations compared to our white Caucasian populations. If we look at our non-Hispanic Black populations and our non-Hispanic other race or multi-race are the ones that are unfortunately being impacted most, right, overall across the board. But here specifically in stillborns. And then our two are right over here. We look at mortality rate, right? So mortality is different than stillborn. Why do we think that is? What's the difference between stillborn and mortality? What was it?
Stillborn is like, okay, you died at birth.
Yes. So stillborn, what's considered a stillborn and a miscarriage, and is really um, when the baby or the fetus died, right? And so usually most OBs and most providers, if the baby is like 28 weeks or further along, then it is considered a stillborn. Um, every provider and people are really mixed on it. So a stillborn is usually somebody who, or baby, I should say, right, or a fetus who died at birth or while in the womb, oftentimes due to natural causes. Whereas a mortality could be as a result of a homicide, right? It could be a result of a car accident, but usually it's a result of something more external and injuries external. So on the bottom here, if we look at the Wisconsin preterm so these are preterm babies. Again, if we are looking at really the non-Hispanic Black African American population, and then our non-Hispanic other race, we can see over and over again really the impact, right, of not just domestic violence, intimate partner violence, but also systematic barriers and issues that are having an impact on mothers and then also the infants or fetuses themselves. Again, low birth rate over here. Anybody have any questions about this slide? Mm-hmm. Mm-hmm. Absolutely. Mm-hmm. Go ahead. Yeah. Genetics. Yeah. Yeah, we'll definitely talk about that. Is it on the next slide? Nope. It's in the next couple of slides. Genetics can, right? But something when we're learning now about more about genetics and where does our genetics actually come from? How do they form, right? And we're really learning now, especially with advanced discoveries in trauma, that our genetics aren't just about, oh, this is what my mama gave me or my daddy gave me, right? It's really about the environment that our parents, right, or even our ancestors were in when I was, just an egg, right, or part of a sperm or whatever that looks like. So that, yes, is my genetics, but my genetic makeup could be or is oftentimes a result of my ancestors' environment. Good questions. Any other questions? All right. So what is the impact then, right, of COVID-19? We talked a little bit about this, but has anybody heard about the shadow pandemic or that word at all? Shadow pandemic really was a terminology that was coined as a result of COVID-19, where survivors and victims of domestic violence and sexual assault were not able to actually reach out and get services and ask for help because of the COVID-19 pandemic. And so since COVID, and I'm not going to say out loud, but I'm hoping, we know that the statistics on domestic violence continues to rise as right, a secondary symptom of COVID. COVID put a lot of stress on families. COVID put a lot of stress on individuals. And so individuals and people are just finally trying to recover from it. And especially now where the COVID-19 pandemic is declared no longer an emergency, many people also then lost their support and assistance over the summer here in Wisconsin. That in itself is going to have another impact on many families, particularly families of color, and particularly families who are from low socioeconomic status. Economic impact of COVID-19 forced survivors to obviously stay in abusive relationships. BIPOC folks or people of color are disproportionately impacted by domestic violence and homicide in the state of Wisconsin. Black African Americans and Hmong Americans are at highest risk of murder suicides during pregnancy. Wisconsin ranks 8th in the nation for the number of women who were actually killed by men. So we're 8th in the country for homicide rates for men who kill women in domestic violence cases. Why do we think that is? What was that? Huh? Mm-hmm. Yeah. Yeah. I think one of the reasons why Wisconsin scores so high too in terms of homicides is I mean, overall as a country, we have a gun control problem, but here in Wisconsin particularly, we have a huge culture of hunting, right? And so a lot of people or a lot of individuals own weapons. Absolutely, culture of drinking. Mm-hmm. What was that? Mm-hmm. Mm-hmm. Yep. So and we also experience higher rates, right, of seasonal depression because of the kinds of weather that we have here. Right. So you put mental health together with hunting, guns, and also alcohol, right? And then you got a recipe for disaster. Mm-hmm. Okay.
Access to marijuana also, as of the legalization in Michigan. And that's gonna play a role in that as well, or, I don't know.
Yeah.
That's kind of a newer thing, but
Right. Yep. Mm-hmm. Right. And I think it's legal in Illinois now too, isn't it?
yeah, Illinois.
Yep. Yep. So all of our sister states.
Correct.
Yeah, because Minnesota, I thought too, right, in like the last 6 months or a year, I think Minnesota passed it for recreational. Yeah.
All three.
Right. Because I remember seeing that about Minnesota, and yeah, I was like, what's Wisconsin going to do? Yeah. Okay. Did anybody read or see the latest publication or released by N Abuse? So in 2022, we saw the deadliest, highest cases of DV homicides here in Wisconsin. So N Abuse keeps those the data, and you can see here, right? The chart that I pulled from them went to 2013, but just in October of this month, a couple of weeks ago, I don't think it was even a couple of weeks ago, maybe a couple of days. N Abuse released their data for 2022, and Wisconsin saw the deadliest, highest number of homicides due to domestic violence here in Wisconsin. 68 individuals died by homicide or DV homicide here in Wisconsin. And then also 22 people or perpetrators or offenders also died by suicide after they killed their partner. And somebody earlier said, well, is it genetics, right? And I think, when we look at this chart here and we think about how did we even get here, we really had to, yes, of course, look at genetics, right? When we look at maternal mortality rates, when we look at perinatal mental health, when we look at, infant health outcomes, right? Low weight, premature, all of those pieces. Yes, genetics absolutely can be a contributing factor, but it's so small to someone's actual life health outcomes. We know, with a lot of new emerging data and research that only about 30% of someone's like behaviors, right? Well, I should say an adult, only 30% of someone's actual behaviors impact their quality of life and how long they actually live. So that means that 70% of our environment will dictate, right, the quality of life that we have and how long we live. That 70% includes, laws, policies, our environment, right, our home, access to healthcare, access to education, all of those different pieces. And so absolutely biology has a huge contributing factor into maternal deaths. It has a huge contributing factor to infant deaths. But at the end of the day, it has such a small impact. And many times we've learned that your biology is a result of generational trauma. And so if my ancestors, right, were experiencing war and persecution and trauma at the time, my outcomes, right, being born now, maybe my health outcomes might be impacted. There was a study that was done by, I forgot what university that was, UCLA or something. And if anyone's interested in reading research like I am, I'd be happy to pass it along. But there was a study done on the offsprings to Holocaust survivors. And this study found that offsprings born to Holocaust survivors had a higher rate of developing schizophrenia at a much younger age and were much more resistant to psychotropic medications, in addition to having more severe positive symptoms. Right. So kind of going back to that generational trauma and genetics, right? Offsprings born to Holocaust survivors had a higher rate of developing schizophrenia, even though they themselves didn't live through the Holocaust. And I think we see that a lot right now too with our BIPOC communities, right? With the generational trauma that, their parents, their ancestors, their grandparents may have experienced. Then our psychology, of course, our psychology has something to do with, right, our health outcomes, our self-esteem, our physiological safety, right? Do we physically feel safe in the environment that we're living in? Do we feel connected with those around us, right? That, of course, is going to impact our maternal health. It's going to impact, infant mortality. It's going to impact, the health of a fetus. But I put trauma up here again because many individuals maybe do not have or did not experience, right, that generational trauma. But if they are, again, exposed to domestic violence in the home, if they are exposed to a lot of drug and alcohol use in the home, that could impact someone's psychology. And really the last piece here is our social and our environment. So this is kind of talking about our social determinants of health. Anybody heard that word before? Yeah, looking at our social determinants of health, or really our policies, right? Health and policy and biases in the policies. And how does our environment, right, actually impact the maternal health and or the perinatal populations and in infants or fetuses. And so discrimination and oppression, we know that our country, unfortunately, is built on our country is built on capitalism. It's built on a free market. And when you have a country built on those two things, unfortunately, you're going to have populations or individuals or groups of people who are going to be discriminated and oppressed. And that has lifelong consequences or generational consequences. Our laws and our policies, we talked a lot about this during our lunch or our keynote, right, during lunch, about how laws and policies really impact someone's quality of life or a group's quality of life, and not just even the immediate group, but long-lasting impact on different generations yet to come. Resources, lack thereof. Trauma exposure again, right? So I put trauma in here in every single layer because trauma happens in every single, it happens very differently. We all experience it differently, and it has different impact depending on how our body, right, how our body responds to it. But it's also our societal values. And why do you think I put societal values up there? Mm-hmm. 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 Yeah. I put societal values on here because right now there's a lot of new and emerging research money or funding, I should say, into maternal health, even though this is not anything new, right? And for a long time, society has really failed this population, right? Because again, we have this stigma of what a woman's role is, right? And so it was your role in life is to reproduce. Your role in life is to be a mom. Your role in life is to do all of these things. You should be grateful that you're pregnant. You should be grateful that you have children. And so we have, excuse me, these societal values and views that are really placed on women that are not realistic, right? And when you are a working person and you have to maybe provide for your family, you're expecting and then you have policies, right? You have laws and policies that says you can only take 6 weeks off. Your job is only protected for this long. That is going to impact the maternal health of an individual or a person who is pregnant. And that is going to impact then, right? Consequently, the fetus or the unborn child and the born child. And so when we look at maternal health, it's not about what the woman did or the birthing person did and why are their health outcomes bad, or why is the fetus or the child's health outcomes bad. Because anytime we talk about maternal health and infant mortality deaths, it's always the birthing person's fault, right? It's always the mom's fault, but we never want to talk about how society actually contributes to it. I also put societal values up there because I'm wondering, we talk about, yes, postpartum depression and anxiety can be experienced, right, or felt by fathers as well. But I'm wondering, where are all the dads and all the men? Go ahead.
And Mary, and then, if it's looked at that you get back to work, then, and that role is for you, like, why is it not reversed? So there's what, these people working in the household, and the same responsibilities to always be there.
Yep. It's so systematic, right? Because think about if you have ever had a child, or you have a family, or maybe you helped your sister or somebody in your family or your friend. Anytime there's a birthing person, providers don't ask about the dad or where's the other person or the partner, right? Like very rarely. And if the father or the dad or the other birthing or the other partner can even take off work, right, to go to all of the different appointments that the wife or the partner has to go to, or they have to take PTO, and maybe they're stocking up on their PTO and their time off for when the baby actually gets here. It's very unheard of or uncommon to have paid, right, paternal leave, and so that's that's going to have economic impact, right, on the family. But even when the baby arrives, I mean, it's really uncommon for OB providers. It's really uncommon for nurses and the treatment team to even ask the father or the dad, like, hey, what are your thoughts, right? Or what are your plans together? It's always directed at the mom.